Welcome this evening to the third What's Up Doc event, the educational series that we launched in the fall. This is our third What's Up Doc, and tonight we are going to be focusing on orthopedic care at French Hospital, another one of our excellent departments and units at French Hospital where we provide amazing care, and we're so privileged and honored to have not only the president and CEO, Sue Anderson, with us this evening, but also Kristen Coyne, our orthopedic program coordinator, a wonderful nurse that is, just rocking it every day at French Hospital, and then followed by Dr. Delagrammaticas, an orthopedic surgeon here at French Hospital. So we're excited to share programming with you, but as is our tradition at French Hospital and within Common Spirit Health, we are going to start with a reflection. And so this is a patient story. This is actually one of our board members and a dear friend, and many of you might know him. This is Dave Garth's personal story, and he shares a little bit about what drew him to French Hospital.
I was very spoiled, like a lot of people, that I didn't really have hardly any hospital experience in my whole life until 2023, and then I had 3 major surgeries. Everyone said, well, when you have your open heart surgery, you don't need to go anywhere else, that we have such a fine hospital here. When I thought about, well, what do I think a fine hospital is? Well, that it's modern, they have good equipment, that their staff is competent, and that was about my level of understanding at that point. But that French was right in the same category, right in the same top tier as these places that people rave about. And I just want people to know that they don't have to go out of town to get top-notch care. And it's so much more than that, I discovered. It's so much more than that. This feeling of caring and compassion that I got from everyone, from the doctors to the nurses, all the way to the people who clean the rooms, was absolutely universal. There was such a feeling that they cared about you. And that, I realized, was just as important as all the other things. Not that the competence and the equipment and cleanliness and all that isn't important, but from my perspective, it just opened my eyes, and I thought, no, my healing, my wanting to get better is so enhanced by this team that is rooting for me. And that's the way I felt. I thought, there's a whole team of people, not just my family, but these people at the hospital that really care and really want me to do well. And psychologically, that makes such a difference. So I have this very special place in my heart for people who are doing that kind of work. Whether it's doctors or nurses or support staff. Sometimes I got the feeling they even were thinking, well, what if this were my loved one? Or what if this was me? What would I want? And I think that's what drives compassion, is being able to put yourself in other people's shoes.
So we're grateful for patients sharing their stories. Maybe some of you have been a grateful patient of French Hospital as well. So I loved how Dave talked about compassion and human kindness, because that's truly the heart of what we do at French Hospital, is we offer compassionate care and a level of human kindness that is not matched, I think, anywhere here on the coast. So up next, we have our president and CEO, Sue Anderson, to share a few remarks about the hospital.
Thank you, Tessa, and I'll start out by saying I am a case in point. I am a grateful patient. I had my hip redone about 2.5 years ago, and it was the best thing I ever did. So if any of you are thinking along those lines and can't sleep at night because it's keeping you up and stuff, I can tell you it's amazing the work that's done here now and how quickly you recover from these surgeries. So it's exciting. You're going to be hearing from both Kristen and Dr. Delagrammaticas today and really learn about our program and our new robot, which is really exciting. But there's other exciting things going on at French right now. We have the thing I like to tout, I want the whole community to know, like Dave Garth said in his video, French is unique, very unique hospital. We have an A rating by Leapfrog, which is a safety and quality organization within throughout the country. We're the only A-rated hospital in San Luis Obispo. We'll just leave it at that. And we are a 5-star rated hospital by CMS Medicare. And we are the only hospital in California with those credentials and one of only 6 across the country with those credentials. So it's pretty amazing. You can look that all up online. It's all publicly reported information, but we have a gem of a hospital here. We really do. That said, the other things that are happening is our tower project out the back. I know you've heard about this for years. We had this little thing called COVID happen after we thought we were going to get going with that, but we are really getting it back on track. We had all the architects and the construction team here last week, meeting with all the managers to make sure that every nook and cranny was where it needed to be, and that it's going to work for people, you know, on the floors and everything. But we really hope that over the next, well, we hope to break ground within about a year and a half on the parking structure part of the project. And then after that will be the hospital building itself. But this project will give us over 100 private rooms, which is so needed in San Luis Obispo, and we'll be able to take up to about 160 patients, which is a lot more than what we can take right now. So very excited to get that project done. You probably read about or heard about, we have our new cancer center that's going to be opening off of Tank Farm and Broad. It'll be a full service cancer center that has not only our Hearst Cancer Resource Center there, but the oncologists, the imaging equipment, a surgery center, physician offices, everything will be in one building. So that's very exciting. We just opened a brand new cath lab. So we have 2 brand new, if you have heart issues, we have 2 brand new cath labs here. We opened our latest one just last month. And the robot, the Mako robot that we're going to be talking about today is a new piece of equipment we got that we're very excited about. So as I turn this over to Dr. Delagrammaticas and Kristen Coyne, as I introduce them, I want to read a letter I got from one of our patients. And this is somebody that's pretty well known in the community. I won't give their name, and I'll try and not say too many names in this letter that was written to me, but it says, I am writing to extend my heartfelt thanks to you and your incredible team at French Hospital Medical Center in our day stay facility. From the moment I arrived, I was met with kindness, professionalism, and a level of care that truly made a lasting impression. The spirit of charism is alive and well at French, and your leadership is clearly reflected in the compassion and excellence that defines every aspect of the day stay experience. He had a hip replacement. That's what I was going to say, just so you know what he's talking about. He said, I would like to offer a special note of gratitude to Dr. Delagrammaticas, whose obvious expertise and skill is remarkable, and Kristen Coyne, the nurse navigator, whose warmth and attentiveness helped put me at ease and made the entire process feel smooth and supported. You have the perfect blend of expertise and empathy, kindness and professionalism, and I'm so appreciative. I'm skipping a couple of names and stuff, but then he said, it's clear that French Hospital and the day stay facility is not only guided by a strong vision of patient-centered care, but also supported by a team who genuinely cares for the well-being of each individual. Please accept my sincere thanks for creating such a compassionate and healing environment. I'm truly grateful. Anyway, it was so nice to get that letter, but I think it really gives a tribute to the team here and to Dr. Delagrammaticas and Kristen, because they're a big part of our team here. And so as I turn it over to them, just know that that's how their patients feel about them. So with that, I'll turn it over to you two.
Thanks for making me cry, Sue. Right before I had to speak. That was a really nice letter, and that's the best part of my job, is being able to make such a huge difference in people's lives and watch their lives improve for the better and be a huge part of that. I love being a cheerleader. So my name's Kristen Coyne, and I'm a registered nurse here at French Hospital. I've been a nurse for almost 20 years, and I have a pretty extensive background in all sorts of different healthcare settings, outpatient surgery, pre and post cardiac cath lab, cardiac rehab department, telemetry, step down units, and med surg. So lots of different areas that I've worked in throughout the years. But for the last 4.5 years, I've been the orthopedic program coordinator here at French Hospital. So thank you for having me, and it's a pleasure to be here, and I love seeing so many familiar faces as well. So Sue is absolutely right. French Hospital is a complete gem. We're so lucky to have such an amazing hospital for being a smaller community. Not having to travel outside of San Luis Obispo is huge. The services we provide are outstanding, and yeah, just very proud overall to work here. Something that sets us apart, if you will, a couple years ago in 2023, we achieved the Gold Seal of Approval from the Joint Commission for our total joint replacement program. So what that means, the Joint Commission is a national organization, and they evaluate hospitals and healthcare, outpatient surgery centers, and they grant these certifications based on whether or not this facility is meeting certain performance measure standards for patient safety, quality of care. They also look at patient outcomes, overall patient experience, and just the overall services and structure of the program, if you will. So that was a really huge achievement. We don't take it lightly at all. It's something we're very proud of, and we work really hard to maintain. So that was a really exciting time, and this picture was taken when we had the news here to do a little segment about us. Just to give you guys an idea of how many people throughout our community that we take care of on a yearly basis. Every year it definitely seems to be growing and growing. It's a very popular club to get a new hip or a new knee. So. But so far, just to give you a glance at fiscal year 2025, which started in July 2024 and goes through the end of June, so we still have another month or so of this fiscal year. But so far, we have taken care of 430 individuals and provided them with a new hip or a new knee, and it's been very rewarding to be a part of that many patients' lives and helping them through their journey. This kind of gives you a breakdown of hips versus knees. We have performed just a slightly more total hip replacements than total knees in the past 10 months, and the average age of our patient is about 71 years old. We live in a very active community where people are living here for a reason. They love to be outside, hiking, paddleboarding, mountain biking, pickleball, you name it. I've treated so many patients who it's just amazing to me what their goals are, and getting them back to living that quality of life and getting them back to the activities that bring them joy. So that's the point of all of this. So here at French, again, we do have that advanced certification from the Joint Commission. We really have a comprehensive program that follows a patient coming in for joint replacement all the way from the time that they are scheduled at their clinic with their surgeon for surgery, all the way through until that post-op visit is complete after surgery's been done for 6-8 weeks, through that final clearance with that surgeon. So it really is just a start to finish walkthrough with that patient. There are several individuals that are a part of your healthcare team here at the hospital, kind of guiding you through each step of the way. Obviously your surgeon, their physician's assistants, their medical assistants at the clinics. Your anesthesiologist is a huge part of this as well. myself, orthopedic nurse navigator. We really focus a lot on providing our patients with as much education up front and discussions about what your expectations are before surgery, what your goals are for afterward, and we tailor it specifically to each person. We provide that ongoing communication with every member of the healthcare team while you're here. You're seen before surgery by a pre-admit nurse. So again, just another measure, if you will, of being able to teach and go over and review things so that you're fully ready and your care partner is also fully ready to be there to support you at home after your surgery's done. Here at the hospital, lots of people are here taking care of you. Your nurses, your physical therapists, occupational therapists, you name it. It's quite a team and it comes together so well. And the goal is to get you home as quickly and as safely as we can. That's the best place for you to heal, and we want to help you achieve your goals. Last but not least on the list, your designated care partner. They are a huge part of your success when someone comes in for total joint replacement surgery. Yes, you are independent when you go home as much as possible, and every day you get stronger and feel better, but having that person to be there after you go home to help with keeping medications in order and helping drive you to your follow-up appointments and just taking that stress off of you at home so you can focus on your recovery is so important. So we include that care partner in as much as we possibly can as well, because they're just as big of a part of your team. So your journey at French, I put this picture in here because I love this sign. You're the hearts and souls of everything that we do. Overall, I feel as if our program provides so much ongoing support and compassionate care. You can really tell that everybody that works here at French wants to be here. It shows, you can feel it. I've worked in huge teaching facility hospitals before, and it's different everywhere else, but French is special. Again, we really work on all of that pre-surgery teaching to get our patients ready for joint replacement surgery. We include their family members, their care partners, and all of that. And overall, the goal of all of this preparation and education, whether it's reviewing a handbook with you, going over medications for pain control after surgery, or having you watch videos that kind of talk you through what to expect. The goal of all of that is to reduce your anxiety and kind of take away that level of fear that naturally comes with having any sort of procedure, especially a big one like a new knee. So we want to take that away as best as we can and be here to support you. Individualized and patient-centered care. We have enhanced rapid recovery protocols that we follow in order to really promote getting you home as quickly and safely, like I said. We encourage early movement, getting up out of bed as soon as you possibly can, really promoting being active after surgery. That's the best way for you to get better quicker. And we really focus on your goals. What is it that you're excited to get back to? Whatever that activity, or maybe it's a big trip later on down the road. Whatever that is, that's something that I always talk with patients about. I want you to focus on that, and that's the light at the end of all of this. That's what you're going to work hard for. And then again, we offer a same-day discharge program. Kind of goes along with that enhanced recovery, rapid recovery protocol that Dr. Delagrammaticas will talk to you more about. But roughly about 45 to 50% of our patients who come to French Hospital for a new knee or a new hip, they are safely discharged home on the very same day. So that's pretty outstanding. It's amazing, and it's so neat to be a part of it and to see that. And again, that care partner, huge part of all of that success as well. But we definitely are very proud of our same-day discharge program. Shorter hospital stay, improved outcomes. That's obvious. Gets you home sooner, you're more comfortable, you're in your own environment, sleeping in your own bed that night, your own bathroom, your own food, and out of the hospital. This slide shows you, again, this is fiscal year 2025, so it goes back to July 2024, but just a month-by-month breakdown of our total volume of our cases each month and what our percentage is of those patients who were discharged home on the same day. So you can see it kind of that uptick each month this year with that percentage growing of how many of these cases were actually performed and patients are being sent home safely on the same day. So beyond French Hospital, the care we provide, the connection that we maintain with you does not just stop the second that we sign paperwork and we wheel you out the door to get in the car. It's much more beyond that. We continue to follow up with you. We call you at home to make sure that you don't have any questions about your medications. We make sure you get signed up for your ongoing physical therapy appointments. You've got your post-op visit set up with your surgeon. We continue to keep in touch with you that way. And again, it's just nice to provide that extra support to somebody from the hospital, that connection to your doctor's office. If you have a quick question and you don't want to leave a message at your doctor's office and wait, for a call back because they're busy too, it's nice to be able to offer somebody just a quick phone call or a text message to just, set their mind at ease. Collaboration with the surgeons and their clinics is definitely something that truly enhances our program. I work with amazing surgeons, their medical assistants. Everybody really, truly cares about the program here at French Hospital. And community outreach is also so important. So this is, I love being here today. And again, I'm just grateful that you all are here to learn more about our program and talk more about the advancements in the surgeries. And it's just something that I think is a really nice way to just incorporate and make it less scary. We're here to support you. And we want to continue to kind of maintain this relationship with our community so that we can continue to talk about what your expectations are and what all is involved, what the advancements in the procedures look like, and maintain those connections with everyone. And then I have my email here. If anyone has any questions, I'll still be here for the remainder of the presentation. But if anyone has any questions, concerns, or anything that I can help you with, feel free to email me or get in contact with the Galzin Foundation. They can always direct you. Thank you so much. Thanks for having me. Okay, and the man of the hour, Dr. Dimitri Delagrammaticas, is here to share some really valuable information with us about our procedures. Thank you so much, Dr. Delagrammaticas. Yeah, forward and back.
Well, good. No, it's honestly a huge privilege to be here today. It's huge privilege to be working with such an amazing team. I think Kristen sort of highlighted it takes a huge village to have success with hip and knee surgery. I always tell patients it's like a team sport. You have to have all the pieces in place, and it really truly is an honor. It's a great environment, great team, and a lot of people that make the process work. I think the surgeon often gets way more credit than is due. So you saw the huge team. So it's a huge credit to everyone's efforts there. So I was kind of hoping to be a little bit more informal, and so a little more question and answer. I think we'll have time for that at the end as well. But don't hesitate to stop me, ask questions if there's anything that I can clarify. But that's not okay? No, that's okay. It'll help me keep my nerves down if it's more informal. So. Okay. Yeah. All right. No. So a little bit about me. I kind of made a full circle. I actually went to college here at Cal Poly. So that was my introduction to San Luis Obispo, the Central Coast. I grew up in San Diego, but went to Cal Poly. Did 5 years, did the victory lap here, and then went to. I worked actually as an engineer for a little bit, and then applied to medical school. So I went to medical school on the East Coast. Did my orthopedic training in Chicago at Northwestern. Was there for 5 years, and then did an additional year in Colorado at a location called the Stedman Clinic. And there I did primarily hip and knee replacement surgeries and hip and knee preservation techniques. And so kind of made a bit of a niche into my practice now, which is primarily hip and knee replacement. So, a major part of what I do day in, day out is hip and knee replacement, and that's sort of my passion there. But made it back. I was like one of the lucky Cal Poly students to figure out how to get a job in San Luis Obispo. So I'm excited for that, for sure. So I got, I showed the punchline. But basically I was asked, what sets French Hospital Medical Center, regarding orthopedic care? What sets us apart? And I sort of, kind of thought, well, how do I rephrase that question? I think, what's been the most significant changes in the past 5 years? So I've been in practice here now 6 years. So what am I excited? What am I proud of what we've done over the last 5 years is kind of how I took that question. I think we've alluded to a few things. The Joint Commission accreditation, huge accomplishment for the team here. The rapid recovery protocols. I think we were nudged that way with COVID and just sort of the logistics that we had, taking care of patients whose hip and knee arthritis doesn't go away because the hospital can't take patients in. And so, the rapid recovery protocols were a huge part of the last, 5-10 years in joint replacement surgery, but, especially here at French Hospital, I think very proud of, how that program has evolved. And then we talked about the exciting stuff, the technology. So, certainly both in hip, but also knee, some robotic techniques, some navigation techniques that we're using. And I think, it's one, another piece in the puzzle that helps patients recover quickly and have a successful outcome. So those are kind of my 3 highlights, and we'll go through a few of those, in the talk here, and certainly can answer questions afterwards as well. I'm going to make the assumption we have no idea, we all know hip and knee arthritis. We know arthritis, and we know hips and knees hurt, but what exactly are we talking about when we think about hip and knee arthritis? And when you go visit your doctor, what are they going to look at? What are they going to ask you about? And just kind of give you a quick primer before we start delving into some of the details about, the kind of nuance of the orthopedic program here. But, so not all hip pain, not all knee pain is arthritis. It's, the most common thing that we see it's related to kind of as we get older and as things break down, we see arthritis as the most common, but it's not always the diagnosis. And so there can be things that cause pain that are not related to the joint, outside the joint. We call those extrinsic, outside of the ball in the socket or the hinge that is the knee joint. Whether it's the muscles, the tendons, it could be related from nerves in the back or other places. And so identifying, is it the hip or the knee, or is it something else? So arthritis, wear and tear, kind of the breakdown of the joint is the most common. That's what we'll focus on the rest of today. But to know that if you're having pain in the hips or the knees, it's not always joint replacement that's mandatory in your future. So common symptoms for hip arthritis. So again, kind of focusing on the wear and tear, osteoarthritis, breakdown of the joints. And the hip pain, it's usually, we think of it as groin pain. The hip joint is actually more in the groin than it is on the side of the hip, where people feel like that bump is on the side. The hip joint is actually more in the groin. So often patients are surprised that, I feel like I have a pulled groin muscle, right? It feels like it's more in the center, and that's actually more common for where the hip pain is located. Often the biggest thing that patients notice is just the day-to-day activities, like tying your shoes, like getting your pants on, getting in and out of the car. Kind of the simple things that seem like they should be simple, but become more challenging as mobility in the joint also decreases. Often patients feel like they can't trust the leg, it's giving out or it's going to give way. Similar symptoms in the knee, obviously a different location. Obviously the knee is more common that the pain is felt in the knee area, but it can be in various places around the knee. But similar issues, mobility, difficulty with day-to-day tasks, and really doing things that we once enjoyed, hikes and pickleball and surfing. Patients that do all sorts of activities and want to get back to heli-skiing, right? You said helicopter skiing. So yeah, all sorts of activities more than just getting around day-to-day with less pain. All right, so what do we typically look at? Is often we look at X-rays to help make this diagnosis for the hips. On the right, you can see a healthy hip on the right side of this hip X-ray, and then the left side an arthritic hip. And basically, there's loss of that space between the ball and the socket. And a similar pattern happens in the knees, where there's a healthy space between the two bones of the knee. That space collapsing down is where the cartilage is breaking down. So that's one of the things that we often will see. The other will be what are called osteophytes, or the colloquial term is sort of bone spurs. So you got bone spurs all around the joint, And that's what we're looking for, these osteophytes. Other things that we see are called cysts or sclerosis, basically little cavitations in the bone or the bone changing its density. And all of these are just X-ray findings that help us give us the diagnosis of what's going on. That you have a breakdown of the joint. Never tells us what the symptoms will be like or how severe or if there will be pain at all. And so basically the X-rays, the imaging just gives us the what it is, not the what to do about it. And really the what to do about it is always based on the symptoms. And so we'll kind of go on to making the assumption we're doing surgery, since that's what this talk is all about. It's the surgical care here at French. So kind of that's the background, hip and knee arthritis. We'll talk about some of the technical basics and technical aspects of joint replacement. So for hip replacement, what is a hip replacement? So we looked at the X-ray of the hip. The hip's a ball in the socket in the pelvis there. And what we're doing when we're doing a hip replacement is actually replacing that ball and socket with metal and plastic parts. A typical hip replacement will include 4 parts. The first part, is this laser point? No. Okay, no, it doesn't laser point, but we have the stem, which goes into the femur. And so here's the X-ray of the femur, or X-ray of the pelvis, the femur portion on the lower part here. There's a ball on top of that stem, and inside the socket, inside the pelvis, is what we call a cup or an acetabular component that goes into the pelvis, and then inside that is a plastic liner that becomes the bearing for the ball and the socket. You often hear, it's a common question we get, is like, how do you get to the hip? What's the surgical approach? And so probably in the past, I'd say decade, there's been an evolution of kind of how we do hip replacement. And it'll tie into sort of the technology that we're using now. But most of us now are using what's called an anterior approach, basically an incision kind of in the front of the thigh. The other traditional approach is what's called posterior. But for me, the anterior approach, probably the biggest advantage is the ability to incorporate technology. So, kind of one of the things that we're excited about here at French is having some technology that helps us be a little bit more precise, a little bit more accurate, more reproducible in our results. And the way that we have patients' positions during surgery for an anterior approach just allows us to utilize this technology in a lot easier way. So X-ray in particular is very easy to obtain during the procedure when the patient's on their back as opposed to their side. And when we do anterior approach, the patient's on your back. And when you do posterior, you're on your side. And so it's not that it's impossible, it's a lot easier to do from an anterior approach. And so, for me, that's probably one of the biggest, I think, advantages. If we look, if we're really honest with the outcomes, at a year, really this shows no difference. But I think in that early time frame, we can make some improvements with anterior approach. And one of the things is being more precise with how we implant the positions. And so we have here at French a software package that takes a look at the X-ray, helps us make some measurements. We can measure accurately the position of the socket. We can measure accurately the position of the leg. We want to make sure the leg's equal lengths and that the mechanics of the leg, as an engineer like the biomechanics, I want everything. I want to calculate all the force vectors and all the biomechanics of the hip, and so we can make those measurements happen. So what we're doing in hip replacement is we make our way to the hip. We take the ball, the bony ball out. We place those 4 parts, the metal part in the stem and the femur, ball, and then the socket. And we can do that with what are called trials. So it's like going to the shoe store. We have all the shoes. We try what size fits. Orthopedics is glorified carpentry, so it is. So to use it, it's a wood shop. Yeah, so we go to the wood shop as opposed to the. But so just like going to the shoe store, we try to fit what is the proper size. We have during the procedure many different sizes to help us find the correct length of the leg, correct position side to side of the leg. And so we place these trial implants and we can take an X-ray of both the non-surgical hip and then the surgical hip. And the software allows us to then superimpose those 2 images. And basically what we're trying to do is create a perfect mirror image. So, what God gave you on the left side, we want to make perfect on the other side that we're operating on. So, basically what we can do is take that X-ray of the non-operative, X-ray of the operative, invert those, and then what you'll see on the video is that we're moving those 2 images, superimpose each other to really judge, did we recreate a perfect match? So we'll go through that video. There we go. So basically we have both images superimposed, so we'll kind of get things set up here. And again, during the procedure, we're actually doing this in real time. We're moving the images around, we're taking the different X-ray images. We can slide between the non-operative and then the operative. And basically we want it to look like it's the same hip, just with one with an implant in and one without. And so, the software allows us to make some manipulations of the position of the X-ray, making sure everything is perfectly lined up. But at the end of the day, we can leave the operating room knowing that what we plan to do is what we achieved. While the patient's still, still under anesthesia and still can make some adjustments if need be. So, really excited about having this tool at our disposal. So that's hips. Now we'll move on to knees. So yeah, please.
How long does the procedure usually take? An hour?
Yeah, a couple hours is typical. Yeah, usually a couple hours. Yes?
How long does a knee replacement last?
Yeah,
Forever?
so not forever. Yeah. Hip and knee replacements I put in the same bucket. Usually we counsel patients, it's multiple decades, and it's sort of a nebulous answer in that the parts wearing out. So what's happened, probably the biggest advancement in maybe the last 10 years as far as the materials that we're using are related to how we process the plastic piece. In previous generations of the plastic, we would be able to measure certain amounts of wear every year. We'd say, all right, it's 10 millimeters thick and measure a millimeter a year, so 10 years, right? So there was a measurable wear rate in the way that plastic was processed. About the turn of the century, there was a change in that, and the more contemporary plastics are really not wearing in the same way that we saw previous. And so it hasn't been around for 30, 40 years, but in the past 20 years, I have seen hips that look like they went in, very recently. So we're hopeful that it will be, many decades, but the parts wearing out is probably an unlikely reason why something may fail. Now there can be a lot of other reasons why joint replacements may fail, whether the parts loosen from the bones, or fractures, or infections, or other complications that can happen. But I think wearing out of the plastic is probably becoming less and less of an issue than it was previously. Yeah.
There's quite a lot of soft tissue around these joints. So, what are strategies that you guys use to mitigate that process of basically pulling on a ligament, tendon, muscle tissues? The recovery process is much slower, or much
quicker.
Yeah.
Yeah. I think it's trying to be very meticulous with the techniques and in the surgical approach. And every surgery is a little different. Everyone's body is a little bit different, but I think part of the anti-approach, part of what you'll see with the robotic surgery, does allow us to be maybe a little bit, we have sort of the secondary checks, so we can be a little bit more, less extensive with our exposure, utilizing some of the technology to then, kind of give us the information we would otherwise need by, opening the view to a greater extent. Yeah. It's about trying to do a very good job, I guess, is the short answer. Again, every surgery is a little different, it sounds very arrogant, but no, I think it's very, you try to be as meticulous and attention to as much detail as you can. And again, utilizing this technology is sort of one additional, tool that we have at our disposal to be that much more precise.
Yeah.
Yes.
How much does the component weigh?
A couple of pounds, yeah.
So will your legs feel heavier?
No, most patients don't notice it. Yeah. I cannot be blamed for any weight gain. So.
Exactly.
Yes, I saw that question coming in. Yes.
I understand the older you get, the more dangerous it is to be under anesthesia a long time.
Yeah.
So what's the best way of handling this?
Yeah, and I'll speak to a bit of the rapid recovery protocols, and anesthesia is a huge component to that. And so to sort of to jump there a little bit, the way that we like to typically do this procedure is with a regional type of anesthesia. So we call it spinal anesthesia, similar to you have a C-section or a delivery, in which we numb you from the waist down. And so that allows us to do the procedure with more of a sedation type of anesthetic. And we find that patients actually tolerate that very well. For me, age is never a great indication to do surgery. So if it's just, well, I should do it now that I'm younger, because maybe I need to do it later, I think the symptoms really should be the driving factor, because you never know. Maybe you never have to do surgery. That's the least risky thing you can do. And I think, again, this community is inspiring, because, we see our, 90-something-year-olds hiking, running past us, and, doing all these activities. And so age, I think, a healthy, active 90-year-old is a better surgical candidate to me than a unhealthy 60-year-old, right? And so I think there's a lot of factors that go into it, and age is just one of those small factors, not the absolute factor. Yeah. Yeah.
I got plenty of questions. I'm gonna
Certainly.
have one more though.
Certainly.
What keeps the components in the bone? Is it just the force of the bone against the component, or is it actually a glue, is it resin?
Yeah, good question. So for a little different for hips and knees. For hips, traditionally we do what's called a press fit or a friction type fit. The surface of the implants is actually a porous metal, very similar architecture to actually native bone. And so for most cases, we'll actually impact the stem and the socket with some friction. And over a couple of months, the bone will actually grow into the implant, recognizing it as itself. The other alternative is to glue, so like a resin type of material that we can seep into the bone and glue the stem. A little less common, usually more for softer, more fragile bone, osteoporosis, and so it's a little bit. We have typically both available, and it's a matter of whatever is the safest technique to achieve fixation. For knees, traditionally it was the reverse. Typically cementing is the most common technique. I'd say in the past 5 years, the manufacturing of the metals and that porous metal has actually been adopted into the knees, and we're doing a lot more cementless or press fit type of knees. And the same concept where we place it into a friction fit, and over time the bone will actually grow into the implant. A little bit newer technology, I'd say probably 5-year track record so far, which has been positive, but it's not the same history as with hips.
Awesome, thanks.
Yeah.
Good question.
Certainly.
So as older adults,
Yeah.
some of us are chronic steroid users and don't have optimal bones.
Certainly.
So, I mean, low dose, even for 10 years, can be a problem. So how do you approach those?
Yeah, I
For
think
me, I'm talking about me.
for me, I mean, same as with the hip. I think there's risk factors for every surgery. There's a risk for every surgery. Some of those risk factors are modifiable, some of them are not. And an osteoporosis is often one that we can't immediately adjust. If your blood pressure is through the roof, or your diabetes is not well managed, or you're a smoker, those are things we can make changes to. Sometimes the quality of the bone is not something we can immediately change. And so having these different types of implants or different surgery techniques will allow us to still provide the similar outcome despite the quality of the bone. Certainly the risks may change. So risk for a fracture, for example, with the implantation of the implant may be higher for someone with osteoporosis as opposed to someone without. Mm-hmm. All right. We're missing the robot. That's what we're all excited to talk about. Yeah. So these are great questions. So excited to talk. I know that's a good question. It's a hard question. I was like getting grilled in residency again. So knee replacement, I think kind of similar concept to hip. We think of the knee replacement more as a resurfacing as a replacement. With the hip replacement, we're basically taking the ball out and putting the ball in. Knee replacement is more of a resurfacing. So as opposed to just like cutting a box out of the knee, we're actually just cutting the surface of the bones, trimming the end of the bone, and placing this sort of metal cap at the end of the femur bone and at the end of the tibia bone. And so a little bit different concept than compared to hip replacement, but similar idea. And so the robot, we're so excited for the robot and to kind of have arrived here at French Hospital. We've been using this technology now for almost a year. It was June that we started. This technology has been out almost I think it's been 15 years. It's like 2011, I think. Mako was actually the name of the initial company that started this robotic surgery. And technology with knee replacement has been a kind of evolution over many decades. Robotics has probably in the past, I'd say, again, 5 or so years, gained a lot of interest. The quality of the robotic systems and sort of the techniques have really improved quite a bit. And so for me, I was a little bit of a cautious adopter. There's been a couple iterations of this robotic surgery. I think previous, maybe not a game changer, and I think the more recent generations of these robotic platforms have been really impressive. To give you some context, when we do knee replacement, the goal is, unlike with the hip, to just restore. You saw perfect mirror image. the knee, we're trying to kind of recreate a lot of different mechanical alignments and numbers. And so when we think of your alignment of your leg, we think of it from the hip down through the knee to the ankle, and everyone's a little bit different. Some are bow-legged, some are knock-kneed, some are rotated every which way. And so we can make those cuts into the bone in different ways to then place the implants in any which way. And so historically, before the use of technology, it was basically looks good. But joking aside, it is, you look to see, is the leg straight? We use these guides that have a long rod that hopefully is straight with the leg, and so that traditional instrumentation was basically a feel, and this looks okay. We have some checks, but it wasn't very precise. Robotics is one technology. There are others, whether navigation, where we similar to the hip, where we're using some eyesights to help kind of make some guesses. I think the biggest difference with robotics now is that we can actually plan what we're doing before we do it, and then the robot can help us translate that plan. So we can, the best laid plans, are, I don't know, was Shakespeare, right? Okay. Anyways, or something like that. But if you can't execute the plan, then the plan is no good. So what's really exciting about the robotic system is that we can make these plans sort of virtually before we do any cuts to the bones, and then execute that with quite a bit of accuracy. And so when we think about robotics, a very common question we get is, are you doing the surgery? Is the surgeon still doing the surgery, or is the robot, doing the surgery? And really, the robot is a tool that we can use. It sort of helps me be more accurate, more precise, but it has no autonomy. It doesn't work by itself. It doesn't move. It's basically a saw with an arm attached that helps us position that saw. And so where previously I was with my eye guessing where the saw goes, now the robotic arm helps us move that saw into the appropriate position. So no, it's not, we're not in the lounge with our feet up. It's still just, it's a fancy tape measure and a helpful tool to then execute the surgery. And so again, the really exciting part, I think the real game-changing part of this system is the planning. So basically what we do, we get a CT scan from the hip all the way through the knee and all the way down the ankle. So we look at the whole leg as sort of in its entirety, look at the alignment, and we can look at the shape of the bones. Again, we talked about going to the shoe store, the same as with the knees. There's certain sizes, and the implants there's no such thing as a custom implant. There's implants, there's ways of custom planning it, but there's no such thing as a custom implant. And so we have to figure out how to fit this implant to fit the patient's bone perfectly. And so we can do this virtually. The CT scan allows us to make a three-dimensional model, an image of the patient's knee, and then we can virtually move the planned implant to where we think is going to be the best position. Why I kind of mentioned I was a cautious adopter, that was the previous generation, was just the bones. We just looked at the bones and we guessed on where to put the implants based on the bones. What we really know is that the soft tissues, the ligaments, the muscles, the tendons, everything around the knee is actually what's probably most important in the function of the knee. And the most recent generation of the robot and the system that we have here actually takes into account the soft tissue. So during the procedure, we can make first the plan from the bone, then we can bring the robot in and move the knee through different ranges of motion and see what the profile of that knee is, and where it's tight, where it's loose, where the soft tissues would rather have that implant, and then make some adjustments again before we make any cuts to the bones. Decide, is this the best? Is this going to be the best position of the knee? And then once we're satisfied with that, then execute that plan. So the CT-based planning is sort of the first step, the bone planning. We have this dynamic balancing, basically moving the knee through a range of motion, assessing some of the soft tissue, characteristics of the knee. And then the last part is sort of this haptic system. It's sort of the safety net. The robot only lets us cut where we plan. So as before with that saw, kind of willy-nilly, we can make cuts to the ligaments. We can cut the arteries. We can cut things that could be potentially devastating. It's very rare for those things to happen. Fortunately, that's very rare. But this system, has a kind of built-in a little bit of a safety component to it. So, helps us make these accurate cuts, but also helps us do a better job, really. And so,
Question.
yeah, please.
Do you move the tendons and ligaments out of the way? How do you protect them?
Yeah, so for knee replacement, the way that we do this, we approach the knee just adjacent to the kneecap. So we make a cut into the we call it capsule, or basically the ligament that surrounds the knee. So that, we have to enter some way, so we move that aside. For knee replacement, typically one of the 4 ligaments in the knee, called the ACL, is removed. That's universal to all knee replacements. The other 3 ligaments are typically kept in place, and so we go to medical school to know where those are, and so we have to be careful where they are. The robot, if you, it'll stay within certain boundaries. So that haptics is basically just a kind of a cloud of where it wants to be. If you were to bring the knee into a place that is outside those boundaries, you could certainly still have some. Have to be very deliberate, but yes, you have to be a little bit cognizant of where some of the soft tissues are, just like you would with a traditional approach. But this, keeps us within sub-millimeter distances from where we're planning. So, part of it is knowing the anatomy, knowing where things are, but it does give that added protection.
Okay.
Yeah, certainly. No, that's great.
Do you have to cut into the thigh muscle,
Yeah, the quadricep. So the approach is usually adjacent to that quadricep muscle. So the quadricep 4 muscles, one of the muscles dives a little bit just past where the kneecap is, and usually the surgical approach is just adjacent to that spot. There are a lot of different, just like with the hip, there's different surgical approaches. Some do go through the quadricep. There's pluses and minuses. There's never been one that's definitively better than the other. Usually the traditional approach, just adjacent, we call it parapatellar, just adjacent to the patella, is usually the most utilized technique and most consistent.
Okay, so what does that mean? Does that mean you do have to cut through some muscle?
Not muscle, yeah. So it's technically a ligament, but it's the capsule. Think of the knee like it's surrounded by a big water balloon. And so that water balloon is housing the usual fluids that lubricate the knee. The muscles are attached to that water balloon, so they help move the knee. The kneecap is enveloped in that water balloon, so as you move the knee, that capsule or water balloon is moving around the knee. In order to get into that knee, we make a cut into that ligament, that water balloon, to then access the interior of the knee. So yes, while technically we're cutting a ligament, it's one that is easily repaired and is of no consequence to long-term knee function.
We sew it up.
So back up. Yep. There we go. Yeah. That was the answer. Okay. Sorry, missed the answer. That was the answer. Yes. We leave it how we found it. So, okay. So I think we talked a lot. This is sort of a little bit more detail, but again, what's really exciting about the Mako platform is planning, informing that plan with your kind of real-time intraoperative assessment of the soft tissues, and then being able to execute it. And then the most important, the thing I love the most about the hip and getting X-rays, I know what I did before I leave the operating room. We know what the result is before we get into the recovery room. With the knee replacement, the same thing now. I can move the knee through range of motion. I can push and pull on the knee and see what that result will be. And if we're not happy, we can make some adjustments before we leave the operating room. So a little bit more, just more information to help us decide, are we doing a good job? All right, and really, are we doing a good job is I think the outcomes, the patient's success, and I think again the Joint Commission Gold Seal of Approval for advanced hip and knee replacement is sort of the full title. It was a huge credit to the whole team here as far as how much work it takes to apply for this accreditation, and then B, provide all of the supporting information, and you have to have track record of doing well with regard to patient outcomes, and so it's hard to underscore how proud we are of that accreditation. So some of the metrics that we are looked at and sort of continuously monitored are kind of listed here. We talked about regional anesthesia, so doing spinal anesthesia, nerve blocks, sort of part of the recovery is the anesthetic techniques, the intraoperative techniques that were used. Where patients are going. We talked about same-day discharge or home discharge, and then we talk about also continuously monitoring this. And so it's not like we got this the approval, gold seal, we're good, and we're done. It's a constant look back, constant appraisal of how are we doing, and we should be looking at this data over continuously over the years. Part of this is to participate in what's called the American Joint Replacement Registry, AJRR. So American Joint Replacement Registry is basically an effort by the American Academy of Orthopedic Surgeons to sort of consolidate everyone's outcomes. And so say, all right, how's Dr. So-and-so in, Kansas doing as far as their outcomes, and different metrics that we look at to tell us how patients are doing, and combining that and be able to see trends and what the trends are, like in cementless knee replacement, and we can look at the AJRR and say, all right, over the past 5 years there's been an increased utilization of cementless knee replacements, or more utilization of robotics or of anti-approach and so forth. So help us, are we doing a good job within our own bubble, but also compared to national metrics. And so a huge component of the Joint Commission accreditation is participation in that joint registry. And I think as we look back at a lot of our metrics, very, very pleased with how we compare to the national metrics. And so again, performance metric monitoring. Again, this isn't a static, hey, we did a great job, we've implemented these things, now we're done. It's a constant improvement, constantly looking back to see, are we doing a good job, and are there things that we can improve? And so looking at functional outcomes, looking at discharge disposition, looking at complications, and returns to the hospital, all these sort of things that help us improve what we're doing. Part of the, yes?
I have a question. I always hear about people going to rehab. So a lot of this is done in the hospital, and how long is that? Or, it sounds like people are being sent out really quickly.
Yeah, no, so that's perfect. Thank you for segueing us. That's perfect for those rapid recovery protocols. You're hired. You're part of the team now. So when we talk about rapid recovery protocols, and excited that patients are able to go home right away, it's not that we're just pushing them out quicker. It's that we're able to sort of achieve all the safety metrics in a more consolidated way, and it's because that we're paying attention to all of the details, whether it's anesthesia. It's about the medical optimization before surgery, making sure all the modifiable risk factors are as well modified and managed before, so there's no surprises during surgery or immediately after surgery. It's about setting up the care team, having the safety net of both from the provider standpoint and from a navigator standpoint. Do I have questions? Do I know what medications do I need? Having an education ahead of time. So I think honestly the most important aspect of a patient successfully going through this rapid recovery happens far before surgery. It's all the pre-surgical preparation that really sets it up for success. So by the time surgery comes, it's like, there's no apprehension about what's going to happen, and it's almost like, what's taking so long? I think patients sort of know what to expect, and the process happens very smoothly. I think it's been maybe a mindset shift in the past decade or so, in that going from treating patients like a sick person, someone who has hip and knee arthritis, it's not a sick person. They're a healthy person that has pain that's limiting them from doing what they want to do. And so you have surgery so that you can continue to be a healthy, active person. And so getting up, moving, getting back to that daily, routine and daily life has actually been shown to be the most effective way to recover from these surgeries. And so while it seems very counterintuitive and almost very apprehensive about, like, oh, this is a huge operation that you're going to go through, and how am I going to take care of myself afterwards? All the preparation that goes into it beforehand makes it so seamless that it's you don't need to be in the hospital anymore. Mm-hmm.
So my big concern is I fall. I'm not planning to.
Yeah.
And suddenly I need surgery of some kind.
If you fall, yeah. That's unfortunately, falls are, and broken hips and are a common thing that we see. I think fall prevention and trying to be safety at home, pulling up rugs and using walkers and so forth are ways to help prevent falls. They happen at a high rate, and so. There's if you fall and break your hip, we'll take care of you in the same way that we would, if you had an elective joint replacement. But
so what if I fall and it's a bad fall? Would I be getting? Who would I get? At that last minute.
So logistically speaking, there's a several. If you've fallen and you need an orthopedist, there are several orthopedists who we each take turns being available And so there's 6 of us that are, 365 days a year, there's one of us available to take care of you. And so at all hours of the day, or there's one of us here. Yes.
I just want to say, to make you feel at ease, I fell. I was fortunate that Dr. D was on staff that day. But from the time I fell in Paso to the time I went home in San Luis Obispo, it's just a little over 24 hours.
Wow.
I had none of the pre-stuff because I didn't have arthritis. I fell, I broke my hip. Thank you so much. I broke my hip around 10 o'clock in the morning in Paso. Ambulance ride, everything. I wanted to come here. I got lucky. 5 o'clock I went into surgery. 8:30 I was in my bed awake. The next day by 2 o'clock I was home.
Oh, whatever.
And yeah, walking up the walk. Thank you.
Yes.
I think it's incredible. It's basically like taking a sectional and fitting it through a doorway.
Yeah.
And you figure it out. I'm not talking about the soft tissue if you're curious about that.
Certainly, yes.
I'm curious about it. So a hip replacement is essentially a labral tear surgery process. And in a sense, so you have to go through the hip capsule to actually replace a hip. You have to cut that open and then sew back up.
Yes.
And knee replacement is also an ACL replacement surgery as well, because you have to cut that and then reinstall it. No.
No,
Okay,
I don't think either of those are accurate statements.
Okay,
Yeah.
cool.
Yes. Okay.
That's what I thought. So that was my.
We need a whiteboard. So they can go through this and draw. Yeah.
So what I thought you said is that when you replace the knee, the
Yeah.
ACL treatment has to be
Removed.
removed.
Yeah,
Right?
it's removed. Yeah. So the knee replacement actually substitutes the ACL. So there's no ACL in a knee replacement.
Okay, so one is not put back then.
Correct.
Got it.
Correct.
That was
Correct.
my
Yes.
question. And then
Yes.
the label tear kind of concept.
The labrum. So labrum, think of it as just the rim of the socket. So the cartilage. So there's cartilage is the surface of the bone. As it extends to the rim, we call that the labrum. In a hip replacement, that's cut out as well. So
that doesn't go back.
It's gone.
Okay,
Yep.
that was
Yep.
my question.
Yeah,
I just
yeah.
kind of stated it in a way that what I thought.
Yeah.
And you corrected that.
Yeah, no, certainly. So the cartilage is removed, the bone is removed at the surface of the bones.
Because I was curious, like, how would you recover from an ACL tear with in the XA? It just doesn't.
No, it's totally different surgeries. Different procedure, different.
It doesn't even go back in.
Doesn't go back in.
Thanks.
Yes.
So if you're going to do a knee replacement,
Certainly.
and the patient may or may not have already had a hip done,
Yeah.
if perhaps when that hip was done, maybe a decade ago, they were doing this on it,
Yeah.
it might, the leg may be shorter or longer than the other.
Certainly.
And so they've been dealing with that for 10 years. If you are doing surgery on the knee, you can possibly correct that then.
No.
I mean, how do you know
Yeah.
how long that leg needs to be at the end of the operation?
Yeah, so knee may be a little different than hips in that we don't have as much leeway in controlling the length of the leg. The alignment of the leg we do, and so someone is, as an extreme example, very bow-legged, and we make that leg straighter, that's going to change the length of the leg just by the geometry there. When we do knee replacement, really the most important factor in the function of the knee is sort of the balance of the ligaments and the soft tissues around the knee, so that the knee moves through a range of motion smoothly, that it's stable and not unsteady. And so you don't have as much liberty to change the length, but as we do the knee replacement, sometimes the length will change, and we're talking in the order of millimeters. So we'll increase or decrease the length of the insert in the knee between the two parts by usually a couple millimeters, so very small amount, something that's usually not perceivable. Most, hip replacement, typically we'll say a centimeter is unperceivable, so it's quite a bit. 2 centimeters, is not perceivable. So we have a pretty broad strike zone to hit. In knee replacement, we just don't have much leeway to adjust that. Yeah. Yes.
From a caregiver perspective on
Yeah.
this, and I actually have 3 family members who will be getting these 2%.
Yeah.
2 are in their mid-70s walking with canes.
Yes.
And I'm just trying to be realistic about, I know it's in and out surgery, it sounds like, but actual hands like, after surgery?
So,
What does that kind of look like for a patient in that age?
yeah, and I want to clarify too, not every patient is a good candidate to go home the same day. But we treat every patient as if that's the plan, because that's the best chance for success with the surgery. So again, not being in bed, getting up, moving is really the hallmark here. And part of it is, again, the preoperative optimization, the intraoperative with the the anesthetic techniques and our surgical techniques, and then how we manage pain and function afterwards. But part of it is probably most important is the help that we implement in place. So the care team that we talk about. For most people, I think this first couple of weeks, most people are pretty independent back to their baseline level of activity. At first they were encumbered by the hip or knee pain, and so their level of activity is compromised in that sense. The surgery certainly will compromise their activity, but they're usually feeling better actually from the arthritic pain, less obviously the surgical pain to get through. So I think most patients are surprised. Most are surprised, like more independent than they were expecting afterwards. And I think trying to coach patients that you're going to be independent. Yeah, they've been so long dealing with a difficult hip or knee that yes, it's different. Surgery, it's major surgery. There's no question that we're not taking this lightly, that it's a minor surgery. But the mentality should be more like this is an empowering thing to get me back to the level of independence that I want. So I think from a safety standpoint for a caregiver, those first 2 weeks is usually the most maybe unpredictable. For some patients it's day one and they're see you later, and others are a couple of weeks or even several months, kind of a little bit slower, and that's okay. Everyone takes a little bit different time. I think that the first year is an evolution of getting better for everybody. It takes time. But as far as being safe and independent, most in those first couple of weeks are at a place where they're comfortable with less direct attention from their caregivers. Yeah, I'm gonna come over here. Yeah, you gotta keep talking. Your peripheral. I'm sorry.
I just have a preventative question.
Certainly.
On that extrinsic versus intrinsic pain.
Yeah.
And so, like, if you have extrinsic pain that you don't really know what it is, but you take a long walk and you sport, whatever.
Yeah.
At what point are you concerned? Does that grow into intrinsic if you don't deal with it? Number one.
Yeah.
And then I'm sort of thinking it from a car philosophy. Like, you keep driving on a spark plug that's not working, and at what point does that just domino?
Yeah.
And so what do we have to pay attention to when we know to come see you?
Yeah, no, good questions. So the short answer, Colleen, you can help me here. So no, not all extrinsic pain turns into intrinsic pain. I think there's a lot of things that go hand in hand. So as you're walking, your gait changes from maybe some intrinsic pain that you're not recognizing. Often that maybe will overwork the muscles or vice versa. And so I think it's important to kind of have that conversation with with your doctor and say, all right, what's the true source of the pain? What are the treatment options? And going in that regard, a diagnosis of arthritis or muscles aches and pains, it doesn't mean there's only one treatment option. And when we think of surgery, it's always, in my mind, the last option. We should try all the things less invasive and less involved before you get there. That option for surgery will always be there, whether it's you've blown out all 8 spark plugs or it's only one that's going out. And so it's really your tolerance of the symptoms, your ability to do the things that you want to do, that helps you decide how invasive you want to go about treating this. And again, that line in the sand is unique to you. Like if I go on a hike and it's a little sore and I can deal with it, but your x-rays are horrible, you should keep going on your hikes and deal with it. But other patients maybe not as severe or are encumbered by their pain and they decide to do something surgical. So again, it's a conversation there's no answer. There's no right answer. It's an individual decision. Yeah.
My question relates very much to what you're talking about, soft tissue extrinsic pain.
Yeah.
I have a diagnosis. It's tendinopathy.
Yeah.
And I would like to know what you do for that.
Yeah. Send you to excellent physical therapists typically.
I've been to PT.
Yeah.
I've been to PT.
Yeah.
3 rounds.
Yeah. So again, there can be some nuances as to like what's causing the tendinopathy and what's what's
It's
the
the
underlying?
collagen. The collagen is collapsing, and from what I have learned
Yeah,
from my research, this happens often post-menopause.
it does,
The
yeah.
estrogen levels drop and the collagen diminishes.
It can, absolutely, yeah.
So what
Yeah.
do you do?
Sometimes we don't have there's no magic wand sometimes. And so some of these things, it's about, mitigating symptoms and managing the symptoms as best we can. We can't change collagen or, subtle tears and sometimes. There's a lot of nuance there. It's
Okay,
yeah.
So is that a surgical possibility, or can you fix a tendon?
It depends on there's a lot of factors there, yeah. So it depends on the nature of the tear, the quality of the symptoms, the duration of symptoms, the location of the tear. And so there's a lot of factors. Typically, around the hip or knee, degenerative type of tears are not usually well managed with surgery. Would be maybe a general
So
blanket.
is there any other option then?
So sometimes medications can be sometimes helpful. Injections can sometimes be helpful. Anything else? So we have an excellent physical therapist. So I would keep looking at, So it's hard to say. It's hard to make a blanket statement. There's a lot of individual factors that can play into it. A tendinopathy or inflammation of the tendon, tears of tendons, depending on location, the duration of symptoms, the patient, again, the treatment options may or may change very drastically. So it's hard to make a blanket
If
statement.
you have arthritis, you can have a hip replacement. You're
Correct.
as good as new.
Correct.
If you have tendinopathy, it's like years and
Yeah. So again, going back to that slide, like not all tendinopathies are tendinopathies. It's which muscle, which tendon, what's it associated with as far as are there other conditions, whether in the spine, or the hip, I guess the most common probably is tendinitis in the side of the hip, your glute muscles, and oftentimes no, surgery is not a great option to manage that. And so it's about managing the symptoms, doing what you can to do the activities that you enjoy. It may include medications, whether again everyone's ability to take certain medications varies based on overall health and so forth. So I don't want to make any blanket statements, but certain medications, anti-inflammatories or injections may be part of that treatment algorithm, but it's hard to say for sure, what it may be, for you. Yes.
About the total replacement. When you still have cushion between the bone, and arthritis is building up between the kneecap and the knee, is there any surgical solution for that?
Yeah,
or any solution that you can see?
Yeah, it's uncommon that it's isolated to one part of the knee, just the kneecap. It can be. It's not to say we never see that, but it's uncommon that it's one part of the knee. Replacing parts of the knee, so partial. We didn't talk about partial replacements. There's ways to replace just parts of the knee if some of the cartilage is missing. Again, some nuance as far as what indicates a patient for that. Is it more widespread? Or is it really truly focal? So, but yeah, there are some options if there are focal areas of the joints that are affected. Yes.
In this protocol, interoperatively, you've got spinal anesthesia and nerve block, but no general anesthesia. Is the patient awake and responsive?
No, good question. Yeah, so most patients don't have good enough jokes or want to participate in surgery, so we want them asleep. So typically what's done is a light sedation. So I'm sure many have had a colonoscopy before. So where you're breathing on your own, you don't have a breathing tube in your throat, not an inhaled anesthesia, but an IV type of sedation. So the spinal, the regional. We have had patients who do not want any other anesthesia and are completely awake, and the spinal takes care of everything that we need for the surgery. But most do not want to participate in that, and so an IV sedation is what we do on top of that. And most patients do not, just like with colonoscopy, sometimes you kind of remember bits of it, but but you have some periods of lucidity, but most do not remember anything. Don't remember going back most of the time. So to the operating room.
I'm unclear. Are
Yes.
you saying that you do a spinal, but then you give them a little injection too, or what else?
Through an IV, we give a medication that helps you sleep. that puts you to sleep.
But it is not like general.
Correct. So you're breathing. The difference is that you're breathing on your own. You do not have a breathing tube in your throat in which a machine is breathing for you. That would be full general anesthesia. This is in which you're.
Enhancing the other.
Correct. Yeah, exactly. It's making you comfortable in the operating room. An unfamiliar environment for you. Yep. Yes. Good. No apologies.
So what's the difference between, I've been doing some research, doing some reading, between robotic and this nano? Is nano the same? Do they do robotic and nano as well? I mean,
Yeah. So how do I answer this question? So nano, it's a branding for a surgeon. We'll leave it at that. So it's knee replacement. I'll leave it at that. So again, how we I think the most important factor is how we execute the surgery, how we put those implants. So the implants, again, there's no such thing as a custom implant. The metal parts are manufactured off the shelf. That's how it is. But how we put them in, again, this is, I would argue, a custom planning. We plan specifically, patient-specific planning is sort of what we're doing here. And the robot, again, is a tool that helps us execute that plan. Other ways of doing knee replacement, you can have the plan, but how do you execute the plan can be variable.
so do they use robotic in that other procedure?
I'll maybe allow them to speak for themselves, but the answer is no. Yes.
So I have a question for both
Yes.
you and Kristen,
Yes.
actually. If you could share a story or maybe a case that you are particularly proud of from your career where...
Oh my goodness.
Yes. Here we go. But no,
I was a little emotional there, so thank you for coming.
Something that maybe resonates with you that was powerful for your career up to this point?
Yeah, and honestly, it's so rewarding, what we get to do. And I think you get way too much credit for the whole process. It's a huge team and a huge effort from a lot of people. So I get the benefit of the patient coming back and sharing that directly to me. So I wish if you go through this process, you should come back to the hospital. Talk to your nurse, talk to Kristen, go to the OR. They deserve a lot of the credit, honestly. But one story actually that's kind of fun. So I enjoy mountain biking and surfing, being outdoors, Central Coast things. So I was riding at the Pismo Preserve. I was climbing. I don't know if I'm sure others have hiked Pismo Preserve. So there's a trail. It's called a Panhandle, and it goes basically to the top of Pismo Preserve. You overlook the ocean, beautiful spot. And it's a who's hiked the preserve, right? And so the Panhandle is a bear of a hike. So a couple of buddies and I were riding up there, panting, out of breath, like struggling to make it up. And one of my patients comes jogging up. Hey, Dr. D, walking her way, hiking, and so we took a picture of the top of the Panhandle, and that was exciting. So that was an awesome moment.
What about you, Kristen? I totally agree. I think being able to see my patients out in the community after they've recovered and reconnecting, whether it's at the grocery store, I actually ran into a patient. We had a mutual friend and we were at a baby shower together. And she was just, I love that. That's the best part of being a nurse, is seeing people get better. So that's my favorite part of all of this.
Yes.
These forums are so wonderful too because you educate in groups, so it gives us the ability to go back and think through this. You don't have to do it one-on-one every appointment again and again. So it's really wonderful, and thank you for providing these.
Time saving.
Yeah.
Yeah, so let's do one more question.
When you say safe to drive, as a primary care doctors, we always get this question.
Yeah, no, it's a great question. So we've actually done studies. We put patients after hip or knee replacement into driving simulators, and it typically takes between 2 and 6 weeks for a patient's reaction time to come back. Usually, the right with automatic transmission, the right leg, a little bit closer to 4 to 6 weeks. But usually tell patients between 2 and 6 weeks. And so the legal answer is you can't be taking anything that alters your mentation, so any narcotics or anything like that. Want to make sure you're safe to do so, but that's the general recommendation.
Colleen had something.
Yes.
I just, on that note, also one of the most common questions, and if you want to give your 2 cents on when you allow people to go back to golf, hiking, and pickleball?
Pickleball never, unless you want to be back in the office. No, I think everyone's a little different. I think most patients probably, I think 3 months is sort of a milestone that, often patients will feel like they're kind of turning the corner. So between 6 to 12 weeks, first 2-3 months, starting to incorporate those activities, whether golfing, chip in putting early, and then playing around the golf as time goes on, riding the bike or hiking and so forth. But in total, the first year, there's an evolution that happens of healing strength, your endurance, your tolerance for more activity builds. But I think a lot of patients are introducing new activities in those first couple of months.
Oh, sure. Go ahead.
After surgery, just out of curiosity, how do you get through TSA at the airports?
Yeah. You become their closest friend. Yeah. So you don't need to carry cards or identify. A lot of the TSA screening, they have X-ray, so they can identify that it's a joint replacement. They'll typically do that. If it's sometimes they'll do a metal detector. You have the scar to prove what's there. So most patients have no issues with TSA. It may require additional screening, but not. It
takes longer.
It can be. Yeah, it can be. Yeah, you get a wand. Yeah, exactly. Yeah.
Well, we are
Yeah.
so.
No, I'd say Kristen stand up there.
Oh, okay. Yeah, please. I thought that there might be another
No,
question.
there was.
Let's
I did
do.
this.
Let's,
Oh, okay.
Not a question.
I was getting ready to clap.
Okay. Okay. Well, yes. Big thanks to our amazing.